Welcome to this edition of ECG 5-Minute Consult, brought to you by Jonathan Barney and Bill Hayden, co-authors of ECG for First Responders, available at Amazon.com. ECG 5-Minute Consult series highlights 10 potentially lethal ECG diagnoses that may go unrecognized. These include Wellen syndrome, digoxin toxicity, pulseless ventricular tachycardia, cardiac tamponade, and today's case. You arrive on scene responding to an emergency call for a 25-year-old actor who fainted. Bystanders say he passed out during rehearsal. He is now awake but feels lightheaded. He says he felt hot under stage lights and became dizzy. He was unconscious for less than a minute. He has had a non-productive cough for the past 2 weeks and taken an antibiotic prescribed by his primary care doctor. He can't recall the name of the medication. He has had similar episodes of lightheadedness in the past, but never fainted. He denies any injury from his fall. On-scene vital signs and physical exam are normal. Stat glucose reading is 101. He has no significant past medical history other than lightheadedness and recent cough. Medications include an antibiotic, although he's unsure of the name, ibuprofen as needed for pain, and over-the-counter vitamins. Paramedics obtained the following 12-lead ECG at the scene. Using the ECG primary survey approach, first responders should address these 4 questions. Number 1, rate. Is the heart rate too fast, tachycardia, or too slow, bradycardia, causing signs of cardiac instability, such as chest pain, altered mental status, shortness of breath, shock, hypotension, or heart failure? Number 2, rhythm. Is the rhythm supraventricular or ventricular in origin? Number 3, ST segment. Are ST segments consistent with ST elevation myocardial infarction, STEMI, or non-ST elevation myocardial infarction, NSTEMI? And 4, T waves. When present, are T waves consistent with STEMI or NSTEMI? Primary survey examines heart rate, rhythm, ST segments, and T waves. You can estimate most heart rates by applying the 300, 150, 100, 75, 60, 50 sequence rule. On the rhythm strip, starts where a QRS lands on a small box grid line. If the next QRS lands on the next small box grid line, the rate is approximately 300 beats per minute. Or, should the next QRS from the starting point land on the second small box grid line, the rate is approximately 150 beats per minute. In the rhythm strip below, the rate is approximately 60 beats per minute. You can also estimate rate by counting the number of QRS complexes that occur during a 6-second time period, 30 large boxes, and multiplying by 10. Our patient shows no signs of cardiac instability such as chest pain, altered mental status, shortness of breath, shock, heart failure, or hypotension due to heart rate. Rhythm. In this ECG, QRS intervals are narrow, as defined by a width less than 3 small boxes. If QR intervals are less than 3 small boxes, the rhythm is presumed supraventricular in origin. If the QRS interval is greater than 3 small boxes, with no associated or discernible P waves, consider the rhythm ventricular in the setting of acute chest pain. Ventricular rhythms are unstable and may deteriorate to ventricular fibrillation. ST segment. ST segments should always lie on the isoelectric line. Elevation above the isoelectric line in two adjacent leads indicates infarction, while depression indicates ischemia. In this ECG, ST segments lie on the isoelectric line. Test your knowledge. Based on your initial impression of this patient's history, physical examination, and ECG, you suspect that this patient's acute symptoms are due to A. Vasovagal episode, B. Transient ischemic attack, C. Cardiac abnormality, D. Acute hypoglycemia, or E. Simple faint. The correct answer is cardiac abnormality. Vasovagal episode is possible only after ruling out more serious conditions. Transient ischemic attack, very unlikely. His young age and nothing in the history suggests this. Acute transient hypoglycemia, doubtful in view of the stat glucose reading. Simple faint, same as in choice A above. The primary survey did not show any immediate cardiac emergency involving rate, rhythm, ST segments, or T waves. However, this ECG is abnormal. Once the primary survey is completed, a secondary survey should follow, screening for other significant abnormalities. Secondary survey items include measurement of PR and QT intervals. A PR interval measuring greater than 0.2 seconds, 5 of the smallest boxes on the ECG grid, is first-degree AV block by definition, a notable but not a life-threatening finding. The QT interval, however, is abnormal. Measure the QT interval from the beginning of the QRS to the end of the T wave. One rule of thumb is that a normal QT interval should be less than half the preceding RR interval. Note: smallest box on ECG grid equals 0.04 seconds at normal paper speed. Thus, 1 second equals 0.04 times 5. In this case, the QT interval should be 1/2 the RR interval of 1 second, that is 0.5 seconds. This individual has an abnormal QT interval of almost 6 seconds. Note, when QT interval is greater than 1/2 the RR interval, only about 50% of cases are actually associated with long QT syndrome. A more useful all-purpose measure of a long QT is a QT interval greater than or equal to 11 to 12 small boxes on the ECG grid. QT interval shortens as heart rate increases. QT interval lengthens as heart rate slows. A corrected QT interval adjusts for these effects. Several formulae are available to calculate QT, such as Bazet, Hodges, Federicia, and Framingham. Opinion varies as to which is best. Reference charts are also available, as are online calculators, such as mdcalc.com. Corrected QT is expressed in milliseconds. 1 second equals 1,000 milliseconds. QT is prolonged if greater than or equal to 470 milliseconds in men, 11 to 12 small boxes, or greater than or equal to 480 milliseconds in women, 12 small boxes. Corrected QT greater than 500 milliseconds is associated with an increased risk of torsade de pointe. Corrected QT is abnormally short if less than 360 milliseconds. 9 small boxes. Torsade de pointe is a form of polymorphic ventricular tachycardia associated with a long QT interval, first identified by François Desertin, French physician, in 1966. Torsade is a life-threatening arrhythmia. Treat torsade with IV magnesium per local protocols. This ECG tracing is an example of torsade de pointe. Causes of long QT syndrome may be congenital or acquired. Congenital mutations in sodium, potassium, or calcium channels may prolong the QT interval. Acquired long QT syndrome may be the result of electrolyte abnormalities such as low potassium, calcium, or magnesium. Numerous drugs are associated with long QT syndrome. These include antiarrhythmics such as amiodarone and procainamide, various antibiotics such as erythromycin, as well as several antidepressant and antipsychotic medications. Evaluation of long QT syndrome. Suspect acquired long QT syndrome if previous ECG is normal, if no first-line family members have similar symptoms, if no exposure to suspect medications, if no electrolyte abnormalities on testing, and if no suspected hypothyroidism. Suspect congenital long QT syndrome if similar symptoms are present among first-line family members. If so, obtain ECG on family members. Consider genetic testing on patient and family members, although this involves an expensive workup. There is also a short QT syndrome. Short QT syndrome is an extremely rare genetic disease caused by a QT interval typically under 0.36 seconds. There are acquired cases as well due to metabolic and electrolyte abnormalities such as hyperkalemia, acidosis, and hypercalcemia. Many people may be asymptomatic, but the majority will have symptoms such as palpitations, dizziness, and fainting. 4 out of 5 people will have atrial fibrillation. These individuals are also at risk of sudden cardiac death due to ventricular arrhythmias. Treatment of long QT syndrome may include medications such as beta blockers, medical devices such as implantable cardioverter defibrillator, and surgery such as left sympathetic denervation. This case featured a 25-year-old actor with syncope. His ECG was abnormal with a long QT interval. Long QT interval is associated with long QT syndrome and torsade de pointe, a lethal arrhythmia. This is an ECG diagnosis you do not want to miss. We hope you enjoyed this edition of ECG 5-Minute Consult. Be sure to check out our book, ECG for First Responders, available at Amazon.com, and visit our website, ecgforems.com.